Hey everyone, welcome back to Shock Doc Medical. I'm Dr. Rod, and today we're going on a deep dive into one of those diagnostic puzzles that can really trip you up in the clinic, diagnosing Purpura. Now, have you ever wondered how a seemingly simple rash can hide a whole host of potential systemic issues? Buckle up, because we're about to break down every step of the diagnostic flowchart for Purpura. And trust me, by the end of this episode, you'll have a toolbox of information that you, as clinicians or even curious patients, can actually use. All right, let's start with the basics. Today's topic is all about how to diagnose a patient with Purpura. Purpura refers to those red or purple spots on the skin that result from bleeding underneath. It might look like something superficial, but it could be a sign of a range of conditions, from platelet disorders to vasculitis, and even coagulopathies. So whether you're a doctor wanting to sharpen your diagnostic skills or just someone fascinated by medical mysteries, this episode is for you. Picture this. You're in the exam room and a patient presents with these skin lesions. The first step? Ask, are the lesions palpable? Now, this is our fork in the road. If the lesions aren't palpable, we're dealing with macular lesions. If they are palpable, we have a different pathway altogether. For non-palpable lesions, the next step is to check the size. If the lesions are 4 millimeters or less, you're looking at petechiae. If they're 5 millimeters or more, they're ecchymosis. Then for petechiae, the next step is to get a platelet count. And here's where it branches out even further. If the platelet count is low, less than 150,000 per microliter, you'll refer to what we call Table 25-1. If the platelet count is normal or high, more than 150,000, you move to Table 25-2. On the other hand, if ecchymosis, check out Table 25-3, which covers issues like liver disease, vitamin K deficiency, or conditions that cause decreased dermal support, such as actinic purpura amyloid, or even Ehlers-Danlos syndrome. Now, if the lesions are palpable, we take a look at the shape. If they're round, that's your classic palpable purpura. Think leukocytoclastic vasculitis, which we'll cover in Table 25-4. But if the lesions are retiform or branching, you need to ask, is there surrounding erythema? If yes, that leads you to Table 25-5, which includes conditions like ankylosing, polyarteritis nodosa, pyoderma gangrenosum, and chilblains. If no, then it's likely due to a micro-occlusive process. Enter Table 25-6 with culprits like calciphylaxis or purpura fulminans. And note, in early stages, these might not even be palpable. Table 25-1. Petechiae with low platelets, less than 150,000 microliter. Let's get into Table 25-1. When you see petechiae with a low platelet count, a few things jump to mind. Clinical features. You might see mucocutaneous bleeding, nosebleeds, increased bleeding during menses, or even bleeding with minor cuts. Sometimes there's also splenomegaly or lymphadenopathy. Initial diagnostic evaluation. Start with a CBC with differential and a peripheral smear. If the patient is anemic, check the reticulocyte count, LDH, haptoglobin, and bilirubin levels. Now, if hemolysis is on your radar, you'll also need to evaluate PTT, PTINR, fibrinogen, D-dimer, and even run a Coombs test and ANA. And if you're still not sure, don't hesitate to consider a bone marrow biopsy. Now, under this table, you'll also encounter specific conditions. Immune thrombocytopenia, ITP. Typically, you see a female predominance with an insidious onset. For primary ITP, the hallmark is an isolated decrease in platelets, often less than 100,000 per microliter, and it's a diagnosis of exclusion. In secondary ITP, it might be related to viral infections. You might run serologies for HIV, HCV, HBV, EBV, or even PCR for parvovirus and CMV. Other tests could include checking for H. pylori, ANA, pregnancy tests, antiphospholipid antibodies, or TSH levels, thrombotic thrombocytopenic per TTP. Here, the classic pentad, though you don't need all 5, includes thrombocytopenia, hemolytic anemia, altered mental status, fever, and renal dysfunction. You're looking for schistocytes on the smear, elevated reticulocyte count, high LDH and indirect bilirubin, low haptoglobin, normal coagulation studies, increased creatinine, and decreased DAM13 levels in idiopathic cases. Disseminated intravascular coagulation, DIC. This can show a spectrum of bleeding and thrombosis, sometimes even soft tissue bleeding in muscles or joints. It's often triggered by trauma, shock, infection, malignancy, or obstetric complications. Labs will show increased PT-INR and PTT, low fibrinogen, positive D-dimer, and other hemolysis markers. Drug-induced thrombocytopenia. Think of drugs like quinine or Bactrim, which can cause petechiae with isolated thrombocytopenia. Bone marrow suppression. This could be due to aplastic anemia, myelodysplastic syndrome, certain drugs like thiazides or antibiotics, alcohol, cirrhosis, or even malignancies. The smear might show pancytopenia, blasts, hypersegmented neutrophils, or leukoerythroblastic changes like teardrop cells or nucleated red cells. Table 25-2, petechiae with normal or high platelets, more than 150,000 per microliter. Now, if your platelet count is normal or even elevated, we turn to Table 25-2, platelet function disorders. These often present with mucocutaneous bleeding as well. In the evaluation, you'll look for splenomegaly or lymphadenopathy and run tests like a CBC with differential, peripheral smear, BUN, creatinine, LFTs, and platelet aggregation studies. If you suspect von Willebrand disease, VWD, or a dysproteinemia, you'll need VWF studies or even SPEP-UPEP. Congenital or inherited disorders. For example, VWD is usually autosomal dominant. You'll see decreased levels of VWF, reduced VWF activity, often measured by the ristocetin cofactor assay, and decreased factor VIII, confirmed with a VWF multimer analysis. Acquired conditions. These could be drug-induced, related to liver disease, uremia, or even dysproteinemias. Medications like aspirin, NSAIDs, clopidogrel, or ticlopidine are common culprits. In liver disease, abnormal LFTs with increased PT-INR or PTT are seen, while uremia will show an increased BUN. Dysproteinemias will have their own SPEP-UPEP abnormalities. Thrombocytosis. Secondary to myelofibrosis. Here, you might see massive splenomegaly, fatigue, weight loss, and fever. A peripheral smear may show leukoerythroblastic changes, and a bone marrow biopsy could reveal a dry tap with severe fibrosis. And if there's no obvious platelet abnormality, consider pigmented purpuric eruptions or capillaritis. Think of clustered petechial hemorrhages with a yellow-brown discoloration, often seen in middle-aged or older men, like Schamberg's disease, which gives a cayenne pepper appearance. Sometimes, a biopsy is needed to differentiate this from vasculitis. Hypergamma-globulinic purpura of Waldenstrom. Often seen in women, these present as recurrent crops of petechiae or purpura on the lower extremities that may burn or sting. They can be primary or secondary to autoimmune diseases like Sjogren's or SLE, or even rheumatoid arthritis. Labs here might show hypergamma-globulinemia on SPEP, increased titers of IgG or IgA rheumatoid factor, an elevated ESR, and sometimes a positive ANA, anti-Rho, or anti-La. Table 25-3, ecchymosis, lesion size to 5 millimeters. Moving on to ecchymosis, those larger areas of bruising. Table 25-3 guides us here. Procoagulant defects. These patients are more susceptible to deeper bleeding into soft tissues. Look for an increased PT-INR and sometimes an increased PTT. Anticoagulant effects. For example, if a patient is on warfarin, you'd see an elevated PT-INR. Liver disease, often with a history of alcohol abuse, hepatitis, or other primary liver conditions. Labs will show increased PT-INR, increased PTT, and abnormal LFTs. Vitamin K deficiency. This might be seen in states of malnutrition, like in alcohol abuse or malabsorption, maybe from prolonged antibiotic use, and you'll again see an increased PT-INR. DIC, as we mentioned before, DIC can also present with ecchymosis, and the lab findings are similar to those we discussed earlier. And then, if the issue is due to decreased dermal support from the vessels and minor trauma, you get into conditions like solar or senile purpura, common in older patients with sun-damaged skin, especially on the forearms. Usually no additional testing is needed. Corticosteroid therapy effects. Look for features of Cushing's syndrome, central obesity, a dorsocervical fat pad, moon facies, along with skin atrophy and telangiectasia. Scurvy, vitamin C deficiency. Think of a diet lacking vitamin C with features like parafollicular hemorrhage, corkscrew hairs, gingival bleeding, and even tooth loss. Serum ascorbic acid levels will be low, and sometimes you check vitamins like B12 and folate. Systemic amyloidosis. This is a bit more complex. Patients might have hepatosplenomegaly, GI issues like diarrhea and protein loss, and macroglossia. You might see periorbital waxy ecchymotic papules or even pinch purpura. Diagnostic tests include SPEP-UPEP free light chain assays, a bone marrow biopsy if needed, and a biopsy of the abdominal subcutis with Congo red stain for apple green birefringence. Genetic testing might also be considered. Genetic diseases with collagen or elastin defects. For example, Ehlers-Danlos syndrome, which features hyperextensible skin and hypermobile joints, usually autosomal dominant, or pseudoxanthoma elasticum, which gives that plucked chicken skin appearance on the neck. Genetic testing can confirm the diagnosis. Table 25-4, palpable purpura, inflammatory causes. Now let's talk about palpable purpura. When the lesions are raised, you're often dealing with inflammatory processes. Leukocytoclastic vasculitis, LCV. These present as purpuric papules or plaques, typically on the distal legs or in dependent areas. A skin biopsy for routine histology and one for direct immunofluorescence, DIF, is key. LCV can be idiopathic, drug-induced, or secondary to infections. Henoch-Schonlein purpura, HSP, usually seen in patients under 20 years with a male predominance. Remember the tetrad, purpura, present in all cases, arthritis, around 82%, nephritis, 40%, and abdominal pain, 63%, sometimes even GI hemorrhage, 33%. Lesions can be targetoid, and if they extend to the trunk or upper extremities, it may indicate renal involvement. 2 skin biopsies are recommended here, along with lab tests such as BUN, creatinine, and urinalysis. Urticarial vasculitis. These are hive-like lesions that persist for over 24 hours and tend to burn more than they itch. They can be associated with systemic symptoms like arthralgia, angioedema, or fever. They may be triggered by medications like ACE inhibitors, penicillin, or sulfonamides, autoimmune conditions, malignancies, or infections. In addition to a biopsy, labs for complement levels, CH50, C3, C4, CLQ, creatinine, and even viral serologies may be useful. Mixed cryoglobulinemia often presents with an acral distribution along with symptoms like weakness, livedo-reticularis, leg ulcers, hepatosplenomegaly, and Raynaud's phenomenon. It can also be associated with glomerulonephritis and peripheral neuropathy. Testing for cryoglobulins is critical here, and further evaluation may include assessing for Sjogren's, SLE, or hepatitis C. Rheumatic vasculitis, seen in conditions like rheumatoid arthritis, SLE, or Sjogren's syndrome. Patients might exhibit digital ischemia, livedo-reticularis, pericarditis, bowel ischemia, or peripheral neuropathy. Lab tests include ANA, rheumatoid factor, anti-CCP, and specific autoantibodies for Sjogren's. For ANCA-associated vasculitides, we also look at Wegener's granulomatosis, granulomatosis with polyangiitis, typically in young to middle-aged adults with nasal, pulmonary, and renal involvement. Expect a positive ANCA with CANCA anti-PR3 in about 90% of cases. Churg-Strauss syndrome generally affects patients in their 30s to 40s, often with associated asthma and eosinophilia. Look for a positive ANCA, PANCA, or anti-MPO, sometimes CANCA. Microscopic polyangiitis can involve both kidneys and lungs, with ANCA positivity in around 70%, usually PANCA anti-MPO. Table 25-5, retiform purpura with inflammation. Next up, Table 25-5. This one's for retiform purpura that comes with signs of inflammation. Rheumatic vasculitis. This overlaps a bit with what we discussed. Again, you might see digital ischemia, livedo-reticularis, pericarditis, bowel ischemia, or peripheral neuropathy. Workup includes ANA, rheumatoid factor, and complement levels. Polyarteritis nodosa, more common in men around the age of 50. This condition can present with palpable subcutaneous nodules, multisystem involvement, constitutional symptoms, renal or abdominal pain, livedo-reticularis, peripheral neuropathies, and it's sometimes associated with hepatitis B. Lab tests should include ESR, CRP, a complete blood count, and HbA testing, positive in about 30% of cases. ANCA vasculitides and chilblains. Chilblains are particularly interesting. They have an acral distribution and occur in cold, wet environments. The history is usually very suggestive, though a skin biopsy might help confirm the diagnosis. Table 25-6, retiform purpura, non-inflammatory, microocclusive processes. Finally, we come to Table 25-6. This section covers non-inflammatory retiform purpura that results from microocclusive processes. Platelet occlusion. Here, a skin biopsy is combined with specific lab tests to look for occlusive processes. Heparin necrosis, heparin-induced thrombocytopenia, type 2. Typically seen on the abdomen more than the extremities, these lesions can appear at the sites of heparin infusion or injection. They usually occur 4 to 10 days after treatment, or even within 24 hours if the patient has used heparin in the past 100 days. and are associated with a drop in platelets, less than 100,000 or more than a 50% drop, along with a positive T antibody. Thrombocytosis from myeloproliferative disorders. In cases like myelofibrosis, you might see massive splenomegaly, fatigue, weight loss, and fever. A peripheral smear might reveal leukoerythroblastic changes, and a bone marrow biopsy could show a dry tap with severe fibrosis. Paroxysmal nocturnal hemoglobinuria, PNH. This condition leads to complement-mediated hemolytic anemia, a hypercoagulable state, smooth muscle dystonia, cytopenias, and sometimes progression to acute myeloid leukemia or Budd-Chiari syndrome. Diagnosis is confirmed via flow cytometry showing decreased CD55 and CD59, along with evidence of urine hemosiderosis. TTP revisited. As we discussed, TTP presents with a pentad that may include thrombocytopenia, hemolytic anemia, altered mental status, fever, and renal dysfunction. Lab evaluation remains the same as before. Cold-related gelling or agglutination. This involves conditions like cryoglobulinemia, often associated with multiple myeloma or Waldenstrom's, or cold agglutinins seen in certain infections like Mycoplasma pneumonia or mononucleosis. Occlusion, secondary to an organism invading the vessel. Think of invasive fungal infections, Pseudomonas, strongyloidiasis, or even leprosy, particularly in immunosuppressed patients or those with relevant travel history. A skin biopsy is sent for histology and culture, and blood cultures may also be warranted. Inherited hypercoagulable states. These conditions predispose patients to venous or arterial thrombi and, in women, recurrent miscarriages. Lab work should include PT-INR, PTT, and tests for protein C, protein S, antithrombin 3, prothrombin gene mutation, 22-1A, and factor V Leiden. Warfarin necrosis. This can occur 1 to 10 days after starting warfarin, typically in obese women or those with underlying hypercoagulability like protein C, S, or AT3 deficiency. It presents with large, irregular bullae that eventually lead to necrosis, often on the breasts, buttocks, thighs, and even penile skin. Purpura fulminans, a particularly dramatic presentation with branching palpable purpura that rapidly progresses to peripheral symmetrical gangrene. It can be seen with sepsis, DIC, or post-infectiously. Labs show increased PT-INR, PTT, D-dimer, decreased fibrinogen, and thrombocytopenia, with blood cultures and peripheral smear potentially confirming the diagnosis. Antiphospholipid antibody syndrome, or lupus anticoagulant. Patients might present with acute, painful purpura, livedo reticularis, and even anatoderma. It's typically seen in patients under 40 and is associated with recurrent venous or arterial thromboses or spontaneous abortions. Diagnosis is confirmed with positive anticardiolipin or beta-2 glycoprotein antibodies and a prolonged PTT. Occlusion from emboli. For instance, cholesterol emboli often occur in men, have an acral distribution, and are associated with risk factors like atherosclerosis, hypertension, tobacco use, and recent catheterizations or thrombolytic therapy. Oxalate crystal deposition. This too causes an acral distribution and may be associated with hyperoxaluria. Endocarditis. Don't forget, endocarditis, often in IV drug users or those with prosthetic valves, can cause Osler's nodes, Janeway lesions, and splinter hemorrhages. Workup includes blood cultures, EKGs, and echocardiography. Sickle cell disease. These patients might show anemia on CBC with sickle-shaped cells or Howell-Jolly bodies on the smear, and confirmation is by hemoglobin electrophoresis. Calciphylaxis. Finally, calciphylaxis is seen more in females and presents with painful lesions that evolve into well-demarcated, non-healing ulcers, typically on the proximal parts of the body like the trunk, buttocks, and thighs. It's associated with chronic renal failure, diabetes, obesity, and poor nutrition. Lab tests might reveal hyperphosphatemia, an elevated calcium phosphate product greater than 70 milligrams per deciliter, increased PTH, calcium, BUN, and alkaline phosphatase levels. Now, I know that was a whirlwind tour through an incredibly complex diagnostic algorithm, but let's take a moment to appreciate the sheer amount of detective work that goes into diagnosing purpura. Each step, from the initial visual and tactile assessment to the detailed lab workup, helps you narrow down the vast differential diagnosis. And while we haven't dived into specific treatment regimens, since this guide is all about diagnosis, remember that treatment choices, for example, corticosteroids for ITP or plasma exchange for TTP, should always be guided by the full clinical picture and current guidelines. For instance, if treating ITP, you might see regimens like prednisone at 1 kilograms per day, but that's just one example, and dosing should always be tailored to the patient. Why is all this important? Well, purpura isn't just a skin-deep issue. It can be a window into systemic diseases that, if caught early, can be managed more effectively. Imagine a patient with subtle petechiae turning out to have an underlying coagulopathy or even a vasculitis that could lead to multi-organ involvement. Early recognition through careful evaluation can make all the difference in outcomes. This kind of systematic approach helps us as clinicians not only treat the rash, but also uncover and manage potentially life-threatening conditions. All right, folks, that was a lot to digest, but I hope you found this comprehensive breakdown of the Purpura diagnostic flowchart as fascinating as I do. If you're a healthcare professional, I encourage you to bookmark these tables and use this approach when you encounter patients with purpuric lesions. And for everyone out there who's passionate about the latest in medical diagnostics, please hit that subscribe button, like this episode, and share your thoughts in the comments below. What parts of the Purpura workup do you find most challenging? Have you encountered a case where this algorithm changed the outcome for a patient? Next week on Shock Doc Medical, we're diving into another groundbreaking topic that might just revolutionize how you think about everyday medical puzzles. Until then, keep learning, stay curious, and remember, medicine is as much an art as it is a science. This is Dr. Rod signing off. Thanks for joining me on this diagnostic adventure. Catch you next time.